So I'd like to welcome everybody who's with us at the moment. I want to particularly acknowledge Vered Harel, who put this whole event together. Kol hakavod, Vered, and I'm delighted that you approached me as president of Mizrahi. My name is Danny Lamb, to be a partner in this event tonight, and we're partnering also with the Jewish Folk Centre in Sydney. The subject tonight is prostate cancer, issues of prostate cancer. Our speaker will be Dr. Avivit Peer, who is the Director of Clinical Trials in Oncology, an attending oncologist in the genitourinary clinic. And she's dealing with personalised medicine, which is the new frontier for treatment of metastatic prostate cancer. But Vered will say a little bit more, and then Miri Orden. Somebody's speaking there in the background. It's probably better if they're muted. This is part of the umbrella of the Circle of Education of Health program, which is has an important goal of helping to improve health in our community. Mizrahi is as interested in health as any other sector of the community. And there's halachic guidance which says, "V'nishmartem et nafshotechem," and that means that you have to take care of your health. And the matter of prostate cancer is a very, very, very important matter. Tonight is Rosh Chodesh. It's Rosh Chodesh Elul. It's the month before Rosh Hashanah. It's the time when we say L'Shana Tova, Tikatevu V'Techatemu. And we think about good health. So this is an absolutely appropriate event to be taking place tonight. And I'd now like to welcome Vered Harel, who's an outstanding executive director of the Australian Friends of Rambam. She's taken it from nothing to something very substantial. And if you look on the websites, there's been a lot of activity. Vered, bevakasha.
Thank you. Wow, such a beautiful words, Danny. Thank you so much. My name is Vered Harel, and I'm the Executive Director of Australian Friends of Rambam. On behalf of the board of the Australian Friends of Rambam, I would like to thank our partners for the first series of the event. And somebody is not on mute. Hang on, let's see who's not on mute. If you can please mute yourself. Whoever join us, please mute yourself. Thank you. Can you please mute yourself? Okay, unmute them. Okay, thank you. Sorry about that. I would like to thank our partners for the first series of events, Meet the Expert, Dr. Danny Lamb, Mizrahi Organization, and the Jewish Folk Centre in Sydney. And I would like also to welcome some of my board are here as well. Rambam Healthcare Campus is a 1,000-bed world-class teaching hospital based in Haifa. The patient's population is diverse, as Rambam is the major referral medical center for all northern Israel, serving more than 2 million residents and other referrals from over Israel, the Mediterranean region, and around the world. Rambam is respected internationally for its clinical services and innovation in medical technology. Australian Friends of Rambam was established to support Rambam Healthcare Campus to the Australian community. We also facilitate research collaboration between Rambam Healthcare Campus and the Australian medical research institutions. And as Danny mentioned, the other important part of our activities conducted through our Circle of Health program, which has the important goal of helping improving health in our own community, and especially in these challenging times. We do this by conducting a range of health and wellness activities by utilizing local expertise and also using experts based at Rambam. Our program includes various education seminars, such as Meet the Experts, and also practical activities, which you're most welcome to come and see what we can offer. So please, we are inviting you to join our circle, take an action, and stay healthy. Now, details you can find in our website, which I'm going to send it through the chat, ozforum.org.au. Now, I would like to introduce you to our moderator, Ms. Miri Ordan, President of the Jewish Fox Center and the Co-President of National Council of Jewish Women of Australia. Thank you, Miri.
Thank you, Vered. Hi, everybody. Nice to see so many of you. Basically, Danny has said everything that has to be said. We are very honored to have Dr. Avivit Peer with us tonight. And on behalf of all of us, I'm in Sydney, but I also know we have a lot of you in Melbourne. We actually have people logged in from Tasmania as well. I noticed a few names. And we have a few from Israel. So we've gone international tonight. So that's wonderful. Danny has said all there is to say at this stage about our wonderful Dr. Avivit Peer. And so I will not repeat all of that. Obviously, we are going to talk a lot about prostate cancer and all the latest treatments and the developments in that field. The only housekeeping rule that I'd like to add is that you will all be muted, but when Dr. P has finished her lecture, then we will have a little bit of time for Q&A. And I think that perhaps Vered will try and coordinate that together with me, and we'll see how we go. We do have a few questions, and I'm sure people will have a few questions as well. So thank you again for everybody. And now I think the time is for Dr. Avivit P to join and to start her lecture. Thank you so much.
Well, thank you. Thank you for this kind introduction. And this is such a huge pleasure to open this session of Meet the Experts. They're very interesting sessions following mine. I regret to say that I have yet been to Australia, but this is a wonderful interaction. And our team member that visited several of the community sites were very excited with your hospitality and your involvement overseas with our activity in Israel. Today I'm going to talk about an important issue of prostate cancer. I'm a GU oncologist, a medical oncologist. That means I'm treating prostate cancer. This is my main volume of my clinic. I'm also doing some other things like run the clinical trials in the oncology, and I'm also in charge of the clinical trials at Rambam. We actually duplicated extensive work in clinical trials that we do in oncology to the rest of the hospital. But the main thing I do is being a doctor first and foremost, and generally GU oncologist, the vast majority of the clinic is prostate cancer. So I thought that would be an appropriate topic to start with. And another thing is that prostate cancer is going through a lot of conceptual changes in the recent years. And I think every year we have new insight, new treatment options for our patient. But what is different now is that this is the first time that we actually can say that we have personalized medicine for prostate cancer, unlike a treatment that was earlier, accepted earlier. We know that we can have a personalized medicine in breast cancer, in lung cancer, if you heard other lectures, but it wasn't part of a prostate cancer arena, a treatment arena. And now things are dramatically changing. So what I'm going to do is give you an overview of the treatment options and and then move to the new options that are more biological, selected for a group of patients that have specific mutations in their tumors. So we'll start with a general overview of how disease is progressing in prostate cancer. And so most of our patients have a local disease. About 80%, 85% of the patient diagnosed with prostate cancer will be diagnosed with a localized prostate cancer. It could be either in the prostate alone or lymph node around the prostate in the pelvis. Luckily, the vast majority of patients treated for their disease will be cured, and this is a very optimistic field, and this is why I love my work. The local therapy sometimes fails. About 30% of the patients will have some sort of a failure of their local treatment, and for them, disease will progress eventually. So disease progresses to a certain point that it gains more and more volume. Usually metastases sites are lymph node and bones, and we have various treatment options for such patients. At the beginning, the disease is most likely to be asymptomatic. We just see a blood marker that is called PSA that is rising, and many minor symptoms, urination, maybe sometimes for patients with symptomatic bone pain if they have some disease there. But eventually disease does progress more rapidly, and then we need to implement more aggressive therapy for these patients. But what is also encouraging that if we look at about 30% of the patient failing local therapy only and progressing to metastatic disease, only half of them will actually die of the disease. That means that out of 100% of the patient, a small number of patients, it's not insignificant, but a small percentage of the patient will actually die from metastatic prostate cancer. So treating prostate cancer is a journey, and the vast majority of the patients will live with the disease and not die of the disease. And this is a message that I always try to spread to my patients, that this is a marathon run, a very slow run, and we have to think how we manage our decision in the long term. Most of the patients will have a close relationship for years and years to come, and we have to manage very wisely our treatment choices, considering more than anything else, the quality of life. So when we treat prostate cancer, there are many, when patients go online, so they sometimes get confused with two terms that are called hormone-sensitive prostate cancer and castration-resistant prostate cancer. And I think the easiest thing is to start with clarifying these definitions, because it's really confusing, and treatment varies between disease status, whether it's hormone-sensitive or castration-resistant. So prostate cancer is a disease that is driven by testosterone. I always call it that the fuel of the tumor cells is, in many cases, testosterone, the male hormone testosterone. And once disease is diagnosed, we call it hormone-sensitive prostate cancer. That means that the tumor cells has testosterone receptors and testosterone in the surrounding that actually binds to the receptors, go into the inside the tumor cells, and activates the DNA to proliferate, to create more and more cells and extend the tumor volume. If we treat hormone-sensitive prostate cancer, the first thing to do is to eliminate this growth factor that is called testosterone. So the red dots are showing plenty of testosterone that actually cause the cells to thrive and proliferate, and the tumor to extend and send, in some cases, metastases. So at that point, I'm sorry, this is one thing in Hebrew, but at this point, if we eliminate the testosterone, if we eliminate the fuel from the cells at a position of hormone sensitive, we actually cause a depletion that causing a cell regression. So it's a rapid cell regression because there's no fuel to the cells. There's no growth factor to the cell. The cells are very sensitive to the supply of testosterone. We take out the testosterone, and this what happens is a regression of the tumor cells. So this is what we call hormone sensitive. We take out the hormones, the tumor is sensitive. This is why it's hormone sensitive prostate cancer. It could be localized or metastatic, but it's sensitive to the depletion of testosterone, which we call castration. We take out the testosterone, that means we castrate. So it's a chemical castration. The other definition is called castration-resistant prostate cancer. That is a cancer that, although we deplete the testosterone, it is resistant. It will proliferate and progress, although the environment is very low in testosterone. And there are several mechanisms of escape that enable the tumor cells to proliferate, although there is no testosterone. So this comes at a later stage of the disease. Usually, in most cases, at the beginning, the tumor is very sensitive to depletion of testosterone. However, as time goes by, sometimes it could be a year, it could be many years, the tumors start to proliferate. Although if you take blood measures of testosterone levels, we get very low levels of testosterone. So we call it the testosterone is castrated. We see only a trace of testosterone. However, what was researched is that in the tumor environment, in the microenvironment of the tumor, if you sample the environment around the tumor cells, we actually can see that testosterone levels can be normal, completely normal. And this is because the tumor can actually produce its own testosterone. It can produce its own fuel. And this will enable him to proliferate with his own supply. And another mechanism of escape is that it can actually proliferate those receptors that take in the testosterone. So even if we have very few testosterone molecules, there are plenty of ports to let them in the cell and enable the proliferation. And additional mechanism is the cell is very sophisticated and can actually proliferate not through the main pathway, but through bypass pathways. There are very different pathways, about 10 of them that they can actually activate the cell. So sometimes the tumor is very sophisticated and one step ahead. And at this point, we have to add more therapy and we have to take it to the next level. So if we deplete testosterone that is produced by the testes, it could be good enough for a specific time, for a short duration, for a long duration, but eventually we need something else to treat the cancer because it started to proliferate in a low testosterone environment. And at this point we have, when the disease progresses, we have different options how to treat our patient. This is for locally advanced or a metastatic disease. So luckily, we don't always have to offer chemotherapy for a patient. We can go and offer the next generation hormonal therapy. So aside from getting those shots that suppress the testosterone produced from the testes, we refer a patient to start hormonal therapy. Those are pills that they take every day. Most of those treatments are taking 4 pills a day, 4 or 5 pills a day. One of them is called abiraterone or Zytiga in Israel. Every country has a different name, but abiraterone is a generic name, and enzalutamide, called Xtandi. So those are different hormonal agents that suppress the testosterone environment in the tumor cell. Abiraterone actually blocks the enzyme that causes production of testosterone in the microenvironment of the cell or in the cell itself. And enzalutamide or Xtandi blocks the receptors, very strong inhibition of the testosterone receptors. This is very strong inhibition. So either the port of entry is blocked or the factory is closed down, is shut down. So we continue the shots for testosterone suppression, and we add another suppression from the environment of the cell or the cell itself. This is a dual blockage. Continue both therapies to continue and suppress, to deepen the suppression of testosterone. And this is a very effective therapy. This is a therapy that usually keeping the tumor under control for a very long duration. Most of the cases is over a year, sometimes many, many years. I have dozens of patients that actually receive these suppressions for sometimes 2, 3, 4 years, and eventually, when we see the scans are normal, although they had a lot of metastatic sites, sometimes we even consider giving them a treatment holiday, because this is a really, really effective treatment. This is very convenient. They don't have to come to the hospital. We have follow-up for potential side effects. There are no free meals, there are always side effects, but this allows our patient to have wonderful quality of life, unless there's a toxicity, of course, but we can manage toxicity, we can reduce dose, we can do some adjustment in order to ensure good quality of life. So just a very quick slide on these treatments. Abiraterone was approved more than 10 years ago based on extension of overall survival in prostate cancer patient. The one received chemotherapy, the one who did not receive chemotherapy, there was a very strong benefit in the survival. And the same thing with enzalutamide, Xtandi. There were 2 main studies that showed extension of the survival for those patients. But this is not, for some patients, the treatment with this agent doesn't help, and we want to explore other venues of treatment. So we have other options, and sometimes there's no escape from treating with chemotherapy. And a lot of people are afraid of chemotherapy, but sometimes it's not that bad when we can actually make some adjustment that make quality of life reasonable, even with extended duration of treatment with chemotherapy. There are a few chemotherapy agents that we treat. One is called docetaxel, and one is called cabazitaxel. And sometimes we use agents, old agents like carboplatin and cisplatin, platinum-based chemotherapy for more aggressive tumors. These are options that we use. Sometimes we use hormonal therapy, then we use chemotherapy, then we use another hormonal therapy. We have many options how we want to treat our patients. But this is not it. We have additional options for a patient. These are really exciting times to be an oncologist, because it doesn't always have to come to only chemotherapy or one agent that doesn't work. We have plenty of options. Some are authorized and some are not. One important issue with treating prostate cancer is radiopharmaceuticals agents. There are 2 main radiopharmaceutical agents that we use. One is called radium-223, we call it's Xofigo, and one is a lutetium-177 PSMA. Lutetium is not an authorized FDA-approved therapy, but it's been used in Israel since 2016, and there's very extensive use of lutetium in Australia. There's a leading researcher, Dr. Hoffman, that is leading the research with this agent. There's extensive research that he's leading. And so this is something that you may be familiar with. But these two agents are very, very important because the first one, Xofigo, is a nuclear medicine, is a radioisotope. That means that it's something that is injected to the patient once a month, and it's very similar in its structure to calcium, and this will be directed to the bone sites that are involved with the disease. And around the bone site, this will release energy, nuclear energy. This is an alpha radiation that is very, has a short span and is very, very effective in causing cell death in the tumor environment. So we actually, where there's a bone distraction from the bone metastases, there's going to be an increased uptake of calcium. So calcium mimetic molecule will be directed to this area. And once it's there, it will release this powerful energy that has a short span and not supposed to compromise the environment of the bone marrow. And this is an effective treatment that helps alleviating pain and also extending survival. We have a very vast experience with treating with radium. This is an injection that is given once a month. It has minimal side effects and is treated, the patients are treated 6 times. So over 6 months of a period of time. And this is a very effective treatment for patients that don't have a rapidly progressing disease, don't have a disease outside the bone. For those patients, we use this therapy a lot for, this is very, I think over 5-6 years we've been using the radium. So as I mentioned, lutetium is also a form of personalized medicine. This is one of the extensively used personalized medicine in Israel. The tumor cells of the prostate have expression of a protein that is called PSMA. You can do a PSMA PET scan, for those who are familiar with that, and you can use the expression of this protein to target it as with a nuclear molecule that releases a beta emitter therapy. And once we inject this material, there's going to be concentration of this substance in all the areas that express this protein, the PSMA protein. So this is another way to treat our patient. We give every 2 months a treatment, and we continue according to the patient response. So there's always a question with the patients, what is the first patient, what is the first treatment, and what is the later treatment? What to treat first? Do we have to start with chemotherapy? Do we want to start with nuclear medicine agents? Do we want to start with hormonal therapy? So once there is a diagnosis of metastatic cancer, the first treatment we start with is castration. We want to have a depletion of testosterone. This is very inconvenient, but this is the main therapy. And once we have a castration, if there's going to be a presentation with metastatic disease, we start with a dual therapy at the beginning. If it's a localized disease progressing, we add eventually the second-line therapy. So we have different options. As I mentioned, we have the hormonal treatments like Tiga or Standi. We have Xofigo, the radium chemotherapy. We mentioned the lutetium, and we have other options. I'm gonna focus now on how we have options of biological agent for specific population in prostate cancer. And another important venue is clinical trials. We have a lot of clinical trials. I'm conducting about 30 clinical trials in prostate cancer, and we try to encourage our patients to participate in clinical trials because I think we have a great experience, and a lot of times the this actually enables the tumor medicine today, and today could be 5 years earlier than it's going to be available later in the market. So our focus is going to be on personalized medicine. And before I talk on personalized medicine, I want to clarify what does it mean. So personalized medicine is how we tailor the treatment based on molecular and genetic profile of the tumor and the disease. So it's not enough if we analyze the tumor, it's not enough if we target a mutation, but we have to also take into consideration what is the disease status. Is it localized disease? It's extensive disease, and the person treated with this for this disease. So because each treatment has a lot of consideration, including toxicity profile. So when we look at hallmark of cancer, one of the main hallmark of cancer is genomic instability and mutation. Once a tumor is known to have DNA that is unstable, and once there's a repair mechanism of that tumor, of the DNA, the consequence of repairing the DNA is instability and mutation. The more mutation there are, the more chance there is going to develop a tumor cell. Our focus is going to be on the genome instability. If we want to analyze the tumor, there are different ways to do that. So we do it all the time in breast cancer and lung cancer. And what we do, the same thing happens with prostate cancer, but we'll use a breast cancer sample. We can actually take sample from the tumor itself and analyze genetically the tumor cells. We can take a blood test, and for patients with metastatic disease, we can actually identify tumor cells in a blood test. There's a specific machine that actually can differentiate the normal blood cells from aberrant cells that are, in most cases, are tumor cells. And we can take these cells out and analyze them. This is called circulating DNA, circulating blood tumor cells. And another thing we can do is to actually test the patient itself, take a saliva or a blood test, and look for mutations that are germline. Germline, that means that this will be in all the cells of the body, and this will be inherited mutation. So this is something else that we analyze, and you're all familiar with the BRCA mutation that are inheritable, and they are related to breast cancer, to ovarian cancer, and also prostate cancer. So we analyze the germline as well. When we take the tumor samples, we have different methods of doing a test that's called next generation sequencing. We actually take the DNA, we extract the DNA from the tumor, and we analyze it in order to see a specific mutation. And this is translated to a report that tells us whether there are specific driver mutation of the tumors or none. Not all reports will show mutation, but sometimes we have point of interest in specific mutation that will enable us to better understand the tumor biology. So when we say personalized medicine in prostate cancer, what we mean is that we are looking at several factors. And the main factor in focus today is the BRCA genes. It's not only the BRCA gene, it's the surrounding genes that actually have a role in treating DNA damage. If there's a DNA, the DNA strand damage, there are very important proteins, there are key proteins that their job is to fix this damage. And if those little helpers are not working well, so there's going to be a damage repair and there's going to be accumulation of mutations. So BRCA1 and 2 are the main, they are the key DNA damage repair protein. Are very important. And someone is going to have a depletion in the BRCA is going to be a higher likelihood of mutation, more mutation, a higher likelihood of cancer formation. So this, just to give you an overview, a quick look of the proteins. We're looking at several proteins that working with the BRCA. BRCA is the main one, but it's a family of proteins that help the BRCA treating the DNA damage. And we will do analysis, next generation sequencing. We are looking at the other factors as well. So this is a DNA damage, and we have the BRCA genes actually helping to do an accurate repair. The BRCA is a very accurate mechanism that repairs the DNA. Alternative pathway is called PARP. PARP proteins are doing an alternative repair if the BRCA is not active for one reason or another. There's a bypass repair mechanism that is called PARP. PARP is a protein that is not as accurate as BRCA, and when we have a lot of for patients that have genomic inheritance of BRCA, the PARP is the savior here. But the PARP is less accurate, and because it's less accurate, there's a higher chance of mutations. The higher chance of mutation, the higher chance of cancer formation, as I mentioned. So patients with that have germline carrier of BRCA have a higher likelihood of developing breast cancer, ovarian cancer, male breast cancer, very rare but there, and also prostate cancer. We're also looking at pancreatic cancer, but prostate cancer is a main target for us. So our key interest is to look in the BRCA carriers and non-carriers. I will elaborate about that in a minute. So the PARP inhibitors, we take in actually, the concept here is that we take a disadvantage of the BRCA depletion using the PARP inhibitor, and making it the disadvantage gives us an advantage. And why is that? Because we can actually inhibit this protein by medicine that is called PARP inhibitors. All the big pharmas they have their own PARP inhibitors. There are many of them in the market. 2 of them are approved, I will show in a minute. But once we inhibit the PARP, there's not going to be a DNA repair in the tumor cell. No repair in the tumor cells. This will lead to cell death. And this actually is a very important mechanism that helps us fight cancer. So in prostate cancer, this actually, the first time it was published, the concept of treating with PARP inhibitors, which is a concept that is already well established in ovarian cancer and also in breast cancer. For carriers with a germline mutation that can be up to 15% of our prostate cancer patients. Already in 2013, it was published. This is efficacy of the PARP inhibitor in the treatment of prostate cancer. Then follows the main study that's called TOPARP study, was published in the New England Journal of Medicine. And they showed that the PARP inhibitor, it's called olaparib, showed a high efficacy for patients with this mutation. But later on, the studies showed that you don't have to be a germline carrier in order to benefit from the treatment. The tumor can show BRCA mutation as a localized mutation and not as a germline mutation. So the patient can be a non-carrier of this mutation, but the tumor will have this mutation. So this is something that we have to look into as well. So today we test the patients for germline mutation, and we also test the tumor, whether there are localized mutation in the tumor that makes it susceptible to using PARP inhibitors. So another important study that was published recently is a profound study that compared treatment with PARP inhibitors to physician choice. And this study is revolutionary because it tested the BRCA and additional proteins and showed a very significant control of the disease and enhancement of survival for patient carrying this mutation in the tumor or germline mutation that have also tumor mutation, treating with a PARP inhibitor. So you see the graphs are opened very different. There's a huge benefit here for the patient treated with a PARP inhibitor harboring this mutation compared to the normal therapy, which is, they compared it here to hormonal therapies that I showed before. And this was a true revolution. This led to the approval of these two, the PARP inhibitors in the treatment of prostate cancer. This shows you how much the tumor shrinks with the PARP inhibitor. So about a third of the tumors will shrink dramatically. And if you treat with a hormonal agent at this point, this is a later stage of disease, they have a minimal response. So this is a very effective therapy. And this led to FDA approval back in May of two agents. One is called olaparib and one is rucaparib for patient with a mutation in the tumor. There are additional options for a specific mutation. We call it MSI-high, and this could match a patient to treatment with immune therapy. These are only 2 to 3% of the prostate cancer. So our main focus is going to be on patients that have mutation in the BRCA family proteins that makes them adequate candidates to treatment with PARP inhibitors. So these are my last slide that focusing on what is personalized medicine. So we always talk about the biology and the mutation and the microenvironment of the tumor. But when we talk about personalized medicine, there's so much more to that. This is just a little thing in a whole patient, and personal medicine has to take into account a lot of other factors like the patient status, his biopsychological medicine, different treatments options, and a lot of other issues. So my take-home message is that molecular profile of the cancer may help to treatment selection and better address specific cancer profiles. But personalized medicine is much more than specific treatment and include adjustment of medical and social needs of the patients and families. So I think the main message is that in order to make better medicine, we have to have teamwork. It's not a physician working alone with a patient. Has to be a huge support from the nurse in the clinic, social support, family support. We have to have, I always allocate a member of the family to do the logistic management and for the patient to focus on the treatment itself. And of course, the main thing is our patient. So will that conclude? I added my email address if you want to contact me directly and continue with this communication. Okay, so I will stop the share. Okay.
I'll unmute myself now, and first I want to say a very big thank you, and we can continue for a few minutes if anybody has any questions.
Yeah, there are already questions there.
Already? Have you got them? Okay.
Yeah, in the chat.
Would you like to nominate the first one? Do you know who they are?
Yeah, we don't have to say names. Yeah.
May I ask a question? I have one question that I would like to ask. It's to do with the BRCA, well, we call it in Sydney BRCA1 and BRCA2. That's the BRCA. We have a lot of knowledge about all of that because of the breast cancer, and the Jewish factor into that area is very, very big. We are told that more Ashkenazi women carry that gene than others. I was wondering whether it's the same with prostate cancer.
Yes, absolutely. And so I actually showed you the numbers that we can have germline mutation that affect the entire family in about 10 to 15% of our patients. And if we add up the number of patients that have only tumor mutation without germline, this can be up to 20 and sometimes 25% of the patients. This is a main issue. But if we focus on the germline, today, a patient with what high-risk feature of prostate cancer, even a localized disease that has aggressive features. It could be whoever is familiar with the Gleason score and very high advanced disease. The guidelines today tells you to test for BRCA regardless of the family history, because sometimes family history is not informative enough. And so today, really, the practice is really changing, and we're trying to educate the genetic consults that high-risk prostate cancer, high aggressive feature prostate cancer are referred for genetic consult to look for this BRCA. And a lot of time, every time a patient comes, it doesn't have any member of the family with cancer and he's positive. It's a strong reminder that we really should listen to the guidelines.
Yeah, we have a special section in a very big hospital we have in Sydney called Prince of Wales Hospital, where they regularly check the test for the genes, hundreds and hundreds of women specifically. Yeah. Anyone else? Any questions?
Men should not be neglected. It's not only women, men should not be neglected.
No, of course.
This is always, we notice that men, older men, don't have the same voice as younger women with breast cancer. And
Yes.
so this is an important issue.
Yeah. And is it the same as with women with breast cancer, that there seem to be more Ashkenazi women? Are there more Ashkenazi men with prostate cancer?
Well, in Israel, we see, I don't have the number of the Ashkenazi and non-Ashkenazi, but BRCA is more common in the Ashkenazi, but the rate of prostate cancer is much lower in the Arabic population
In the
than
Arab
in the population. Yeah, there's like twice as much prostate cancer. 1 out of 8 is 1 out of 8 or 1 out of 9 Jewish Israeli will have prostate cancer. In the Arab population is 1 out of 17.
Wow.
Numbers are different.
Yeah, yeah.
Okay. Mary, there are questions here.
Yes.
Yeah.
Do you want to actually go to the questions?
We had
Yeah.
a question about does everyone needs to have a BRCA testing?
Well,
That was one of the first things
I
to do.
mentioned,
Or?
metastatic disease and aggressive localized disease needs to have BRCA tested today. When we look at the specific tumor sampling, you can be a non-carrier and still have a mutation in the tumor itself. So this testing is relevant only to patients with metastatic disease, not for localized disease. At the moment, there are no studies supporting the biological agents that I mentioned, the PARP inhibitors in a localized disease. It's only in a clinical trial setting. But in the metastatic setting, this is important additive information that will influence our treatment decision. So this has to be done at one point or another in the treatment. At least after one line of therapy, this information is very relevant.
Thank you. And just one more question, if I may. You mentioned that you have a lot of nuclei-based medication that is being used. I was just wondering that whether that eliminated the very high percentage of men that had to have a complete prostatectomy now that we have all this other fantastic medication.
Okay, so absolutely not. So if the patient has a localized disease, he needs a definitive treatment, a curative treatment. This could be either surgery or radiation therapy. So I'm not a surgeon and I'm not a radiation oncologist, but we refer the patient to one treatment to another. It could be internal or external medicine, radiation. You have, in a few weeks, you have actually a topic on that. on the new frontiers in radiation medicine in prostate cancer, or surgery, which is a very good option as well. The treatment options I mentioned here are for patients that the localized treatment has failed and they have metastatic disease. And also about 15% of the patients actually present with metastatic disease. So the presentation is not of a localized prostate cancer, but rather a metastatic disease that we have to treat the whole body and not just a localized.
Yeah, yeah.
All right, Miri, the question here.
Yes.
Thanks for the information. Are eggs harmful for those with prostate cancer, and does vitamin D help?
Interesting.
Well, the eggs are not known to be harmful for prostate cancer. There's no data indicating randomized controlled trial showing that eggs are harmful. Vitamin D, on the other hand, there's some conflicting evidence that this can be depletion of vitamin D can be pro-cancerous. But it's not a clear evidence. However, when we treat with castration, when we have testosterone depletion, this actually affects the bone health. So when we have low testosterone levels, this will can increase osteoporosis. So when we start therapy for our patients, we always have supportive bone therapy with calcium and vitamin D, and I always check the level of vitamin D and the baseline, and we add the supplements accordingly. So vitamin D depletion is not good for everyone, and I think most of the population has vitamin D deficiency. So this is always something to look out for.
Yeah, especially.
I see a question about the copy of the slides. I will be happy to share the slides with you. I apologize for my heavy Israeli accent and the medical terms here. I see a comment on that, and I have a. I think I addressed the question on operation. So operation is only for localized disease. In Israel, most of the, I have a question here about how to operate prostate cancer, whether traditionally open or robotic surgery. In Israel, most of the surgeons do robotic surgery. I think really more than 90% of the surgeons will have robotic surgery. Most of the patient will ask for robotic surgery. This shortens the hospital stays. It's less painful. You don't have to open the entire area of the prostate, the abdominal, open abdominal surgery. So the hospital stay is much shorter and recovery much shorter. It makes a lot of sense. So in Israel, patients demand robotic surgery, and I would do the same if I was advised to. I always advise to go through this path. Okay, so
there's a question, Dr. Peer. Radiation treatment therapies in conjunction with hormone therapy. You mentioned a little bit about it, or standalone radiation.
Yeah, so when we, for patients that present with metastatic disease at presentation, so this is about 10 to 15% of the patients, we used to start, before 2015, we used to start just with testosterone depletion therapy. And in the monthly or 3 monthly or 6 monthly shots. But recent year data show that if at presentation we actually add another therapy, add chemotherapy or one of the hormonal agents I mentioned, it could be abiraterone, it could be enzalutamide, there's apalutamide, there are about 4 agents out there. If we use them upfront at combination with the testosterone-lowering shots, the survival data, the survival is so much longer for these patients. So today we have dual therapy at the first point of treatment for a patient presenting with metastatic disease.
Mhm. Thank you. Anyone else?
Yeah,
We're getting close to the end.
can we get the slides, please?
Yes.
Yeah, sure. I will send them to Mary.
Yeah. Very also. Yeah.
Of course.
Yeah.
I will send them in 5 minutes, so you'll be able to get them.
All right.
While you are searching, just to say, it was fantastic. I learned a lot. Thank you
Yeah.
very much, Avivit. It's absolutely
Thank you.
fantastic. Thanks a lot.
Thank you.
Yola.
I hope it was not too intimidating for the patients.
Encouraging.
Hope and new frontiers, and it's amazing what we know today is so different than what was here 5 years ago. And
Yeah.
I'm always very excited with the data, and because we have access very early for these new agents through our clinical trials, we are very proud of the level of medicine we have for our patients. This is really exciting.
Can I
Yeah.
ask about circulating tumor cells for early detection? Have you got an opinion on that?
Well, I think we call them wet biopsies because it's a blood sample. And it seems like you can get about 80% of the information compared to from a tumor biopsy. The issue is that sometimes the patient had a localized biopsy from the prostate 3, 4, 5 years before he has metastatic disease that needs to be addressed and analyzed. And sometimes these old biopsy are very hard to give us information of a valid DNA for assessment of the mutations. And getting a bone biopsy is not always easy. So the liquid biopsy could really salvage the situation to give us more informative data. So today there's Janssen is conducting a very large study for about over 10,000 patients that they actually compare the circulating DNA, the wet biopsies, to the those who have mutations are they compare it to the tissue, to the old tissue available. So this will give us more information about utilizing the wet biopsies, the circulating DNA. But this is a more and more common method of analyzing a patient. If I have a tissue that is valid, I will prefer that. But if not, we go to the route of wet biopsies.
Yeah. And one last question. Patients always ask about natural therapies. Is there anything that slows the whole process up?
Yeah, actually, there is the one I'm familiar with is called MCP, is a citrus component that slows down localized prostate cancer. Patient with patient who has a failure of localized treatment and don't have metastases. This is the citrus supplement MCP is has shown to slow their disease progression. So sometimes I suggest that to my patients.
And
So everybody, I think that's it for the questions. I say a very quick thank you before Danny comes in. We would like to thank you, all of us from all over the world, to listen to everything you said was really quite inspiring, and we can hear your dedication and we can hear your thoughtfulness and compassion about the whole story with prostate cancer. And for that, we really do appreciate and thank you for all the work that you do. And I'm sure everyone will feel the same. It was very, very interesting and very impressive. So thank you so much. And we hope to have you back sometime in the near future. Danny, you might want to now say a few words.
Thanks very much, Miri, and Avivit Tiashvi Kochech. It was really outstanding. And you held the audience extremely well. Kol hakavod. Vered, thanks for putting it together. We look forward to working together on this program of Circle of Health. Somebody asked earlier about next week's program. Next week's program at the same time, Thursday night, the 27th of August, again at 7 p.m. with Professor Moshe Frankel, Director of Complementary and Integrative Medicine. And the topic will be prostate cancer, the role of complementary and integrative medicine. So let's see each other all next week. And you can do one other thing. You can look at the Circle of Health website, the notice, the one that you got about tonight, and you can look at whether you want to support that activity. And additionally, tell your friends about it. You can see the quality of what was presented tonight. I hope you'll join us and we can grow for next week. Erev Tov, Chodesh Tov, Kol Tov to everybody. Avivit, B'hatzlacha.
Thank you, Dr. Avivit Peer. Thank you, Danny, and thank you, Miri, and thank you, everyone, for joining us tonight.
Thank you very
Have a
much,
good night.
Danny. Thank you, everyone. See you again.
Thank you very much. Beautiful.
Bye.
תודה, אביבית.
Shalom.
תודה.
Later.